I'm Cecily Begley. I'm Professor of Midwifery in Trinity College, Dublin, which is Ireland's oldest university.
And in your keynote speech today, you spoke about the problems with the overmedicalization of birth. Can you explain what is problematic with it?
Okay, birth is a very natural phenomenon, particularly for low-risk women who have absolutely no problem, which is at least 50% of all women. And birth is governed by various hormones like oxytocin and endorphins. And the trouble with oxytocin is that if you upset a woman in labour, if you open the door to her room suddenly, or you bark at her, or you talk about things like you're not progressing properly as you should, that decreases the oxytocin in her body and it slows down the labour. Once you slow down labour, medics start introducing medicalisation. The first intervention would be rupturing membranes, which has been shown to not have any effect. The second one is to introduce oxytocin infusion, which makes the contractions stronger and speeds up labour, but it also causes more pain to women. So then they need an injection of pethidine or a drug, or they need an epidural, and that in turn slows down labour again and also leads to the baby's heartbeat going irregular. So the eventual upshot of all of this, if we're not lucky, is that the baby's heartbeat drops enough that everyone decides we need to do a forceps birth now or a caesarean section. So you have this cascade of intervention. Once you start with one intervention, which can be as simple as opening the door to the woman's room and disturbing her labour, then it sets out a cascade of intervention that ends up, if we're not very lucky, with a caesarean section that shouldn't really have been necessary.
You said that unjustifiable episiotomies are an assault on women.
Absolutely.
Can you explain why?
Yeah, an episiotomy is a cut that's made in the woman's perineum, the very tender area below the level of the vagina. It's made with a pair of scissors, which is not always sharp. We always put in a local anaesthetic first so the woman doesn't feel it. But it's not necessary. It's only necessary in very, very rare cases. For example, if the baby is very, very big, or if the baby's heartbeat is dropping, when the head is right down on the perineum, just about to be born, because it doesn't shorten the length of the birth at all by about 3 or 5 minutes. So when I say it's an assault, that's an assault. Having a cut made in a very tender area of your body with the scissors is an assault if it's not necessary. If we did the same thing to men in an equivalent part of the anatomy, they would be very upset. So unless the episiotomy has a very justifiable reason, it should not be done.
And you warned the Nordic midwives that are here today to not become complacent. What can midwives do to halt the overmedicalization of childbirth?
Yeah. We always look in the rest of Europe to the Nordic areas because they have a very low rate of caesarean section, low forceps. Women tend to have a much more normal physiological birth. But the caesarean section rates are rising. They've gone up by 2 or 3% in the last 2 or 3 years. And once that rise starts, it'll go up very, very quickly. So what the midwives need to do is halt that cascade of intervention that I was talking about. They need to preserve the birthing room for women. Birthing rooms for women should be quiet. They should be dark and warm. Nobody should be allowed into the room that doesn't have to be there. They should have husband, partner, mother, whoever they want with them to support them. Midwives need to use water in labour to help women. It eases the pain and helps them relax. It can be a birthing pool if you have one, but it can also be an ordinary domestic bath that you'd have at home. Or it can be a shower that you spray on the woman's tummy or on her back to help relieve pain. Midwives need to massage, to be with women, to comfort them through labour, support them, to delay as long as possible any interventions that they might need. And that's the way to decrease caesarean section and forceps births.
And as the medicalization of childbirth is becoming a norm in some parts of the world, we need to work with women. I'm not a midwife, and I know that being a woman, it's crucial to have the information to be able to take the right decision about my body and my health and the health of my newborn or my child. So how do we make sure that women have access to the latest research and the information they need to be able to take good decisions?
You are so right, and I think women sadly aren't informed by us as well as they should be, and sometimes even the classes that we run for women in pregnancy aren't are not always giving them the latest research or information. They're maybe telling them how to behave or how we think they should behave in hospital, or they'll be telling them this is what will be done to you when you come in labour. So all women need to go out there and find out as much as they can about labour, always looking at the research, not just internet sites that tell them various things. You need to always be looking for the research. What the midwives need to do is to check the latest research in the Cochrane database, and this is also available to all women, free, usually in most countries, and there's a plain language summary that women can access that tells them exactly what should be done for particular things that happen. So I think women and midwives should work together on this, share the information, and then band together and complain if the kind of care that should be provided is not being provided for them.
Yes, we have to stand up together for sure.
Absolutely.
So Cecily, can you tell us, why did you choose to become a midwife?
Well, when I trained, first of all, there was no direct entry midwifery, which is what we now provide for people, that you can go straight from school or as a mature learner to become a midwife. So I had to do nursing training first. And then I worked for a while as a nurse, but then did midwifery education. And the minute I started, even on day one, within the first week I went in and saw a birth. And I was just so impressed with how the midwives worked with the woman and supported her and guided her and helped her. And then at the birth, the baby came out quite blue. And in fact, to me, he looked purple. And I was very worried. But the midwife just said, we'll just go away and have a little chat now. And she took the baby and she just went over to the corner and, suctioned him out and gave him a little rub, a little bit of oxygen. And he was pink and crying in a minute and came back to his mother. And I just thought, I want to do that. I want to spend my life doing that.